Okay, so we're recording now, so let's get started. I appreciate anybody that's here in person. I appreciate you coming and listening. I really do appreciate it. So anyway, today we're going to talk about image critique, and I uh, I love image critique. I like it looking at images and seeing what I can see on them. Uh, and on every image that we take, there is certain things that we need to see, and that's what we're going to talk about today. So let me just slip over to the slides here, and we'll get going. All right, can you guys see that okay? All right, I'm going to hope that you can see that. Anyway, welcome to LSRT study group number 12. We're moving right along. You know, we probably only have a couple left. I haven't completely gone through them all yet, but we're getting close to where we can start reviewing and get you guys ready to take this test. So anyway, this shouldn't be real long. Should be informative though. Anyway, last week we talked about what needs to be seen on an image as far as legalities go. And you know, those things are patient data, of course, patient name, date of birth, medical record number. The Ascension number is automatically generated on our systems. We need to have a patient history there. So why are they hurting? For how long have they been hurting, and what caused them to hurt? You know, the pain region of interest, symptoms, history of any previous injury to the affected area. All that stuff needs to be on our images, and the information that we send to the radiologist, so they have a pretty good picture of what's going on with that patient. We also talked about markers, right and left markers, how we should be using those on every study that we do. You know, it is a law that an image needs to have a right or a left marker on it, so we know what side of the body we're actually looking at. And we went over a couple different instances where if a marker wasn't placed there, it would cause problems with the patient's diagnosis and possibly health. That's why it's so important that we use our right and left markers. You know, the other markers are great, and those can be put on post-processing in your upright or supine, or what projection you're doing, whether it be PA, AP, or oblique. Anyway, the bottom line is markers are important, and we need to use those to kind of cover our bottoms. So we talked about hanging images, what images need to look like on the computer screen that you're looking at, and the importance of this. And I know it was a lot, and those have gone back and looked at last week's class know that it's kind of a hard subject to discuss because there's so many different facets to it. But I've broken it down into the simplest of simple as I can. Here we've got our skeleton man on the right hand side of the screen here, and we note that he is looking directly at us. That is the anatomical position, with the palms facing us. Okay, so when we hang films, or when a film comes up for processing that we just took, there's a certain way that film needs to look, and I've got it split up between you know, different body parts. So your fingers, wrist, hand, forearm, they all need to be hung fingers up, right? Fingers up. And it needs to be annotated whether it's a right or a left. And our markers can help us with that. And as we go and practice these daily, it's going to become second nature to you. Just remember that fingers, hand, wrist, and forearm are all hung fingers up. Okay, the shoulder, the humerus, the elbow are all hung from the shoulder. So just like we're looking at that skeleton. That's what we need to be looking at on our x-rays. So with the shoulder, humerus, and elbow, they need to be hung from the shoulder, so shoulder down. Knee, femur, tib, fib, ankle all need to be hung from the pelvis, so they're anatomically correct, looking at us on the film. Toes and feet, however, we hang those toes up. So it's easy to remember anything that we have fingers or toes on, they're all going to be facing up. Okay. Whereas, like I said, the ankle, tib, fib, knee, femur are all going to be hung from the pelvis down. Chest, abdomen, pelvis, spine, they're all hung anatomically correct. So they're looking at us, so we can tell what side is the left and what side is the right. And this can save you. You know, if you shoot an abdomen that comes up backwards, you're going to know it's backwards because the right won't be on the right. Okay. And I'm more than willing to go over these as much as you need to so you can understand them. But it's something that is important that we need to understand. And when we're hanging our images for the radiologist, we do it correctly. So this week we're going to go over image critique, meaning what do our images need to look like? What do we need to see on an image? And we're going to go through that today a little bit. There is some vocabulary involved with image critique. These are just words that you need to be familiar with. You don't need to memorize them or anything. Just know what they mean and have a general idea of what they mean. So let's run through those real quick. Gross exposure error, and that is what it is. Okay, this refers to a significant deviation from the optimal exposure settings, leading to either an overexposure or underexposure, resulting in poor image quality and potentially requiring a repeat exposure. So you have an image that comes up and it just looks terrible. It's not diagnostic. You can't tell bone from soft tissue. That is a gross exposure error. Okay, just so you know what that is. Quantum model. I don't know if we talked about this last week or not. Quantum model refers to the grainy or blotchy appearance in an image caused by random fluctuations in the number of photons that reach the detector. Okay, so it's basically an underexposed image. You know, it does look grainy, kind of sandy, and blotchy. And the way to get past that is to at least double your mass. It's just a good thing to know, but know what quantum model or noise is. Spatial resolution refers to the ability of an imaging software to detect between two adjacent structures. This is crucial in visualizing fine details, which is what we need to visualize on the X-rays, the fine details. So nothing gets past us. Just know what spatial resolution is. A distortion is a change in size and shape of the image. We've gone over that. Image artifacts, you know, any flaw to an X-ray image that can obscure anatomical structures, or in some cases can mimic pathology, leading to misdiagnosis. This isn't good. Okay, we need to keep artifacts off our images, whether that be motion artifact or you know, metal artifact. We need to strive to do our best to keep those off of our image so it doesn't occlude anything. Radiation fog is a general darkening and reduction of contrast on the radiologic imaging. Okay, and it's caused by a source other than the primary beam, such as scatter radiation or improper processing. The improper processing we don't have to worry too much about because we don't use a processor to do any of our images, but scatter radiation can bite us in the behind, absolutely, and cause radiation fog. So window width and window level. We just need to know that window width controls the shades of gray and white. Okay, kind of our soft images like a chest X-ray or an abdomen. We control those shades of gray with a window width. Now the window level controls the brightness of the image. More contrast, less contrast, the the distinction between black and white. That's more your window level. Okay, just know what those each do: window width and window level. Raw data is the image or the information that we receive from the image detector. Okay, it's the original sensor data before any image is processed or displayed or adjustments are applied. So your raw data is just a whole bunch of information. Okay. If you ever have to send your images manually, you'll see in the computer where it says raw data. We never want to send our raw data. We want to send the DICOM image. Raw data is just going to be a whole bunch of information there. It's just not going to look good. Okay. That's what our systems are for, to run through the raw data and give you the optimal image that you need. So quantization, the process of converting continuous analog signals from digital image receptors into discrete digital values, allowing computers to process, store, and display images. So quantization is basically a conversion from an analog signal to a digital image. Okay. Corrected data for processing, the application of techniques of software that improve quality and accuracy by addressing issues like non-uniform detector response, scatter radiation, and attenuation. It leads to better diagnosis. So corrected data, that's usually taken care of by our machinery or by our software. There are some corrections that we can make to make our images look good, but know what that is. Post-processing refers to manipulating the medical images after they've been taken to enhance their quality, clarity, and interpretability. Oh, that's a tough word. Aiding in the diagnosis and treatment plan. We actually, post-processing is an important thing that we do. Okay, once that image comes up, it's up to us to make that image look anatomically correct, make sure there's markers on there, and make sure that image is contrasted the way it needs to, so we can get the best diagnostic image possible. Brightness refers to the overall lightness or darkness of an image. Contrast refers to the difference in density between adjacent structures. Pretty plain and simple. So viewing conditions, there's optimal viewing conditions. Refers to the optimal viewing condition, which is including a clean, uncluttered area. Okay. Bright, high resolution monitors, and subdued lighting. Okay. So we need to have a certain type of monitor that allows us to see what we need to see on the x-ray. And these are high resolution monitors. I think in the next class, we'll talk a little bit more about that. But it also suggests monitor angle of 10 to 15 degrees backward tilt. Okay. Just make sure your viewing areas are clean from any major clutter. It's amazing how clutter will make you see things a little bit differently. It's amazing how that happens. An ROI, region of interest. Okay. We have talked a little bit about AEC, automatic exposure control. We don't use it. You just need to know what it is. Okay. AEC systems automatically terminate X-ray exposure when a predetermined amount of radiation has been detected by the image detector. Okay. This ensures consistent image quality and reducing radiation exposure. So I just want you guys to know what this and what AEC is and how it works, just for test purposes. We do all of our techniques API usually, unless you're Rock Springs, and then we do them manually. But you see on these two images down here, it looks like 2 eyes and a nose on the one on the left. And it just looks like 3 rectangles on the other one. Sorry about that. But those are the automatic exposure detectors. Okay, so say we want to shoot a chest x-ray. We've got the patient up there. So we're going to select these two cells because those are the ones that are in front of the lungs, right? So we tell the machine that we don't want to go over such and such a mass. It helps protect us a little bit in case it doesn't work. It's called a backup timer. But we'll select 110 kVp and we want to AEC the mass. So we put our patient up there. We select the two side thingies right here, detectors, and we shoot our image. So just as soon as the optimal amount of radiation hits those sensors, it shuts the image off. It's supposedly giving you a perfect image, which, you know, AEC is wonderful and it works really well if you position well. If you happen to have a bone in front of a detector where it should be soft tissue, it's going to screw your whole image up. So positioning is very important for AEC. You have to position correctly, and you have to choose the right cells to detect how much radiation needs to go through there. I hope that makes sense. Just know what AEC stands for. It stands for automatic exposure control. Okay, and it allows the optimal amount of X-ray photons to make it through to the image receptor, and it'll shut it off, so we have an optimal image. Okay, and just remember that positioning can really goof up your AEC quality. If you don't select the right cells or have the wrong body part in front of the wrong cell, it's a whole thing. Anyway, just know what that is. Okay. So let's get into image critique a little bit here. What do we need to see on a radiographic image? Number one, the entirety of the ordered body part, proper collimation. So if we order a forearm, we need to see the entire forearm joint to joint. Okay, and that goes for any other body part. We need to see the entirety of the ordered body part. 2 or 3 dimensions of said body part. So we're going to do an AP or a PA. We're going to do a lateral, and we're going to do an oblique. And those are just different dimensions of that body part. Okay, very important. Proper brightness and contrast, as well as proper density. Okay, and the more we get going, we're going to learn what images need to look like. Sometimes I know just coming into X-ray cold, you're not sure what things are supposed to look like, and that's what we're going to get better at. Proper spatial resolution, good contrast between 2 adjacent parts in the image. We want to be able to see fine detail between bowel and gas, or bowel and bone. Just good spatial resolution. Become aware of how the body part should look on the screen. Okay. And that's kind of what we're talking about with our hanging protocols. Just know what that body part is supposed to look like in that projection that you shoot it in. And that just comes with practice. For example, upper and lower extremities should have a lot of contrast, okay, a lot of dark and light, whereas chest, abdomen should demonstrate more shades of gray, okay, detail between soft tissues. Okay, just become aware of what you need to see on any particular image. Okay, know your anatomy. Okay, anatomy is important for X-ray. It's not you don't need to know every muscle or nerve or anything like that, but know your anatomy and know where stuff lies. If you're supposed to see something on an image, know what to look for to make sure that is on the image. Okay. All images must demonstrate a right and left marker. We talked about that. Okay. All legal patient identifiers must be demonstrated. Name, date of birth, medical record number, sex. Anyway, all that stuff needs to be on there legally. So all artifacts should be removed prior to taking an image. Okay, pretty cut and dried. Make sure that that they aren't wearing any type of necklace or a thick waistband or bra that they're not supposed to. It's going to show up and make our images not as well. So let's look at a few images here. Okay, so every time you take an image, you should know what you're looking for. So here's a hand series. Okay, So a hand, it includes the phalanges, the metacarpals, okay, down to the row of carpals. And that's what we need to see on a hand. Okay, we need to see the entire hand. And they've done a good job here as far as collimation goes. It's collimated really tight, really, really nice. There's not any big edges. Uh, it looks like to me maybe this hand is a little bit bigger hand, and we need to up the contrast value a little bit. So I would probably double my mass on this picture and keep my KVP the same. Just make sure our density and contrast looks a little bit better than it does. You can't see bony cortical real well. The edges between bone and soft tissue are pretty decent. And they've demonstrated everything that needs to be demonstrated. Phalanges, metacarpals right here, and the row of carpals, okay? So on a hand image, we need to be able to see distally fingers, and proximally, we need to be able to see the radial ulnar carpal joints right here, okay? So whoever took this image, somebody with Sterling, I stole all these images from one PAX. Anyway, good job whoever did it. They did a straight lateral, which is fine. I don't see any artifacts other than the pin that's kind of pointing to an area right there. But, that's not affecting the image at all. No, like I say, no artifacts. So this is a good image. Just the contrast could be a little bit better, but yeah, pretty good. So, okay, so here we got a chest x-ray, and you'll note that the images have really good collimation. That's a great job, whoever did this one in Burley. Nice work. There's proper penetration. Now on a PA chest, we need to be able to see the upper thoracic spine bodies, which we can, okay? That's telling us that we've got enough density, enough penetration there to see what we need to see. Contrast-wise, we're really good. We can see edges of the lungs. We can see apices really well. You can also see the angles, costophrenic angles of the lungs. We can see the diaphragm here really well, and we can see vascularity within the lungs themselves, which is a nice picture. I don't see any artifacts. On this, I don't see any right or left markers. So this should have a left on the left side and a left because it's a left lateral. On the lateral, you can see this graininess right here. Okay, we're a little bit underexposed on that one. We could probably double our mass on this one, and it would turn out a little bit cleaner. You see the quantum model and the noise right here. It's just from underexposure. Okay, our posterior ribs are pretty well lined up on each other. It looks like there's a little bit of rotation there. In a perfect world, our posterior ribs should be lined up right on top of each other on the back of the lateral chest. Okay. Yeah. Other than the markers, a little bit of underexposure on the lateral, we've done a good job here. But you'll note that we can see the entire lung field on both of them, and that's what we want on a chest X-ray. If we happen to cut it off right here, our apices, we need to do another one. Make sure the entire lung field is there on a chest X-ray. Okay, good job. Okay, foot. Good job. It could be collimated a little bit tighter, but it's not the end of the world. We've got good contrast. Very, very nice. We're able to see between bone and soft tissue really well. We can see bony cortici here. Positioning wise, pretty good. Pretty good. We've got our AP, our oblique, and our lateral. I don't see any artifacts. Everything's marked with a left marker, which is great. The only thing I would do different on this is I would have that lateral foot turned up so that foot is standing in front of you, okay, pointing out to the side. So to me, the lateral is upside down, so it needed to be turned right side up, Okay. All right. Good job on the foot, guys. Pelvis. Looks like this one was done in Evanston this year, actually. It's a very nice pelvis. The entire pelvis is seen. We need to be able to see through the lesser trochanters, which are right here. So we've done a good job there. The iliac crest up here needs to be seen in the image. Okay. And, both hip joints need to be seen very well. Now, there is a marker up here. This is the right side, so good job, good contrast. You can see bony edges really, really well between the soft tissue and the bowel gas. Bony corticals is fabulous. The greater trochanters are turned out, which is really, really good. Now, you can tell if you're rotated by the obturator foramen down here, these big holes, they should be symmetrical, which they are pretty much symmetrical. So if one was bigger than the other one, that means that you are rotated towards the bigger side. Okay, this is a really nice picture. This is what you need to see on a pelvis. So very good job. Here's a C-spine. Very nice C-spine, actually. Collimated very well. Lateral, we need to see this articular process right here. It should form a D right there. Okay, that's an anterior process right there that we need to be able to see. We can tell that our image is lateral by that D. If that's a D, you're lateral pretty well. Spinous processes are all lined up pretty nice. We can see 1, 2, 3, 4, 5, 6, 7, and T1. Okay, that is exactly what we need to see. We need to be able to see this joint space right here, and we actually see it clearly, so we wouldn't have to do a swimmer's lateral to get C7, T1, right? It's very nice lateral. The AP is very nice as well. We need to be able to see 3, 4, 5, 6, 7, which we do see. The jaw is actually going to include 2 and 1. That's why we shoot the odontoid picture, the open mouth picture, so that we can see the dens right here fitting into C1 right here. Okay. We also need to be able to see these lateral masses or the lateral joint spaces of C1 as it sits on C2. So this is a really nice odontoid. Positioning wise, these are all marked really, really well. We need to be able to see the outside borders of the mouth, which allows us to see the dens right here and the lateral masses. That's what we need to see in the open mouth. We've got a little bit of the occipital bone on top of the dens right here, which I would never redo this image because it's actually a really nice image. In a perfect world, that den should be without superimposition of the back of the head right here, or the teeth. It needs to be in there just perfectly. And when we go over the positioning of the C-spine, I think it's our next one that we're going to do tomorrow. We'll talk about how to get that as perfect as you can each time. So really, really nice C-spine. Okay. Here's an ankle. It's a great ankle. You'll note that it is marked with an R. Okay, meaning this is a right ankle. And if we look at that image, it's just like that skeleton is facing us. We're looking at their ankle. That's what a right ankle should look like. Okay, with the fibula over here on the outside and the tibia on the inside. Okay, these are positioning really, really great. We got the AP. We're going to have some superimposition with the distal fibula over the lateral side of the tibia. Okay. Now, sorry guys. So here is our mortise view, which is a 10-degree internal angle. Okay, this opens up this talar tibial joint right here, really nice. It also opens the space between the fibula and the tibia right here. Okay, and this space right here is open as well. Your distal fibula as it goes down there and meets the tarsal bones. Okay. Um, so lateral is perfect. Your tibia should be here on the outer or the posterior 2/3 of the tibia, which it is superimposed. We get a really good joint space right there. We can see the sinus tarsi really well as well. Very, very nice. We ought to be able to see the calculus, the calcaneus right here in entirety, okay, and up to the midfoot. So we've done a really good collimating. Contrast is beautiful. This is what an ankle should look like, guys. Very, very nice. I like that they have the foot dorsiflexed, meaning flexed up. That allows us to see the Achilles tendon right here. And sometimes you can diagnose a torn Achilles with an X-ray if it's shot correctly. So anyway, good job. Wrist. Okay, this is a nice wrist as well. Collimation is perfect. You'll note that these are collimated fairly tightly. You don't see a lot of space outside of any bone, which is going to help us get a really good diagnostic picture. The bony cortical is fabulous. The sharp edges are fabulous. Very, very, very nice. We're able to see the radial ulnar carpal joint in each image very, very well. On the lateral, the radius and ulnar are superimposed over each other. There shouldn't be, ulna out here and radius here. They need to be superimposed just like this. Okay. Very, very nice picture. Good job. All right. So T-spine. T-spine's an interesting one. It's a hard one to learn how to do well. We do have some artifacts on this one. Strap of the bra, which isn't the end of the world, just for the fact that it's not laying within the spine, which is what we're looking at. But it would be better if those were not there. Okay. So here we've got the AP. We're able to see all 12 vertebrae. Okay. Which is what we need to see. We're collimated nice and tight. It's a very, very good image. We're able to pick out different thoracic bodies in their joint spaces, which is nice. And we got the spinous processes right here looking right at us, and the ribs coming off the joint. Now, the lateral, you're never going to be able to get through the shoulder girdle on a lateral. So on your T-spines, you're always going to have to do a swimmer's view, which is what this is on the right. But this lateral is nice. So it's marked well. Other than the bra straps, we're in good shape. We're able to see each thoracic vertebral body. Okay, and you'll note that the edges are white. It just usually depicts that the patient has a little bit of arthritis. You can see some rib blur. We're shooting through the ribs to see the spine. Which is nice. Usually a low KVP and a higher time density is going to get you a really nice picture. So here is the swimmers. It's actually a nice swimmers. Okay, here you can see C7. Let's see, C7 right there, and here is the C7T1 joint right there. And it's not going to be perfect, guys, just for the fact that you're trying to pass through that patient shoulder girdle times 2. Okay, so we have to hit these really hard. I usually shoot mine around 70, depending on a regular size person, probably about 150 to 200 mass. You're really giving them the onion, as it were. Anyway, this is a nice picture as well. You can see the spine coming up and meeting the cervical spine right here, and that's what we're looking at, is that right there. Okay, very, very nice collimation job as well. Contrast is great. Other than the artifact, this one's really good. Okay, here's an L spine. I've got a couple different L spines. This is a really, really nice L spine. Okay, good contrast, good density. We're able to see lumbral vertebral bodies really well. We've got the spinous processes staring at us and the transthoracic spines coming out the side there. We're able to see all of those. We're able to see both SI joints, which is what we want to see. We want to be able to see the sacrum where it meets the L spine right here, and we want to be able to see L1 and T12 right here. And we know this is T12 because it's got a rib coming off of it, where the first lumbar vertebrae does not have a rib. It just has the transthoracic bodies here. Okay. Sorry. Anyway, nice picture. Now, I'm not seeing a marker on here. I'm thinking I may have cut it off when I cut the patient's name off. But, you know, our R or L should be on here. This lateral is marked. That's why I'm assuming that this one was marked as well, and we probably cut it off. You can see that the posterior ribs are lined up on top of each other, which is what you want to see. We can see the lateral vertebral body really, really well, and we can see the spinous process that's coming back off the back. Collimation-wise, we're fabulous. We're just collimated anterior to the anterior spine, and we can see a little bit of light on their back right here. So this is actually a really, really pretty picture. Great job, whoever did it. It was Evanston. So this is something in the patients. Well, it's actually the IUD in profile right here that you see over here. So, I mean, that's an artifact that we can't do anything about. So here's another L spine. You can see the difference between the two L spines. This one is underpenetrated. You can see the lightness. You know, you've got poor detail. You can't really see. You can't see the transthoracic spine at all. And you know, it's just a lot of graininess, a lot of sandiness there. Lateral is the same way. Really, really light. You don't have really great detail to any of the bony things. So what would we do on this one? I would probably quadruple my mass. Looks like it's a bigger person. So I'm assuming they shot this 70 at 40, maybe. I would shoot it at least 70 at 160, and I'm sure we'd get a really better picture. But you can see how it's not collimated well, and that just gives us more scatter radiation, which we've learned. When we don't collimate, we end up getting more scatter radiation, which is going to do this type of thing to our picture. Okay, I would probably redo this picture, shoot it a lot hotter, quadruple my mass, and I would collimate a little bit better. Anyway, just so you know what to look for. I don't see any markers on this one as well. So anyway, okay, we're almost done, promise. This is a humerus. It's a nice humerus, collimated really well. It could be collimated a little bit tighter, but man, I'd take this every day of the week. You can see that we can see both joints, elbow joint and the glenohumeral joint right here, right? Both on the AP and lateral, both joints are seen. We've got an L here, and I don't see it on this one, but I may have cut it off. But there needs to be an L marker on the lateral as well. We're able to see the entire bone, right? We're able to see soft tissue to soft tissue, which is what we want. It's actually a really, really nice picture. The only thing they could have done differently on this, on the AP picture right here, is they could have used the anode heel effect. They could have put the cathode over the shoulder and the anode over the elbow, and that would have been a little bit more uniform as far as contrast and density goes on the humerus. Okay, but yeah, very, very nice humerus. Good job, whoever did that. Shoulders are awesome. Anyway, we do 3 pictures here in Evanston. Anyway, we do an AP, a Gretche, true AP, and a scapular Y. And these are good pictures. They could be a little bit darker. It could be hit a little bit harder, but definitely not redoable. You can see the entire scapula on both of your APs, where they come in and meet the humerus right here. Very, very nice image. Okay, now your lateral, or sorry, your lateral, I call it a lateral, but it's actually a scapular Y. Is made up of your acromion and your coracoid process, making a Y right here. Okay, so you should be able to see that Y with the scapula coming down in profile, or a lateral view of the scapula. Okay, in a perfect world, this humerus is going to be superimposed with the lateral scapula right here, but this is actually a pretty nice picture. I would not retake that one. You can see the Y right here really well in the lateral scapula there. Okay. Anyway, I hope this gives you an idea of what we need to be seeing on the images that we shoot. And as time goes on, you're going to get to where you're going to know what you need to look for, and you're going to know what that needs to look like, if it needs a little bit more contrast or if it needs a little bit more density. And a lot of that can be done post-processing, which we've talked about a little bit, as long as there's enough information there to do it. Just really concentrate on your collimation. Make sure you include the entire body part, but collimate as tightly as you can to that body part. Use the API techniques. If they are a bigger person, make sure that you're bringing your technique up a little bit. And I can be reached, and if I don't answer right away, I'll get back to you as soon as I can. But give you a ballpark technique is what will look good. Okay, and I look forward to you guys getting better and better at this. I'll tell you what, when I go through one packs, just makes me happy. You guys are doing a good job, and you're learning and you're putting into practice what you're learning, which I think is awesome. And I appreciate you guys doing that very, very much. Anyway, that's all I got for you today. I hope you guys have a great day, and we'll be back next week and we'll talk some more stuff. But thanks for coming. I appreciate it. If you have any questions, please reach out. Have a good day.
Thank you.
You're welcome.
Thank you.
Later.
Later.
Later, Gator.
Later, Gator.